analytics. So I'm going to switch my camera off, folks, and I'll just carry on. Bear with me. So thank you all for joining us for the third session in this series. Oh, goodness me, there's a screen there. There we go. My name is Lisa Drake, as I said, and we have been running these sessions really to support you in general practice and primary care. Try to think differently around your long-term conditions. You'll have heard me on earlier sessions say that the NHS has had a kind of an unhealthy interest in access for the last 18 months, and I kind of think we need to shift the focus slightly. So bear with us as we run through a few slides just to give you the housekeeping stuff. As usual, we're going to record these events. We've got a landing page which will pop into the chat at the end of the session. It'd be really helpful to know where you're working, what roles you're in, because although we've got a number of people who've registered, they sometimes share links with others. I think your mics and cameras should be off for the start, but we'll hopefully switch those back on later. If not, I'm going to ask you just to post your questions into the chat if that's okay. If the tech isn't working. And then just bear with me one more time. Everything's jumping about on my screen, so I do apologise. We're going to look at this from two different levels. So the team from HN are going to very much take a high level population health view and think about how we're using predictive analytics to look into the future, work out which ones of those patients we can maybe avoid an unplanned emergency admission. And then we're going to flip on to coming from a bottom up and through PCN approach, starting to think about the data that you're holding in your clinical systems and how they can identify streams of work to support your long-term conditions. So I'm just going to share this one panel. In case you're not sure where we fit as Redmore Health, we offer a lot of support to practices and PCNs in terms of change, digital transformation, optimization of products and services, as well as running sessions like this to showcase new solutions that are coming through. So although we're offering these ones today around long-term conditions, this is the kind of plethora of support that we've got on offer to you. You can pick that up in either a 12-week project if you just want to do a focus piece of work, or you can take a longer-term support offer from us for about 12 months. And some of the dashboards that Connor's going to be working through today will be part of that support offer if you're working in a PCN. If you're working in an ICB, obviously developing population health plans across your INT is going to be important. Our support can give you a bottom-up view, but we can also do that high-level ICB support as well for population health. So it'd be useful for me to understand where you are at the moment and what tools you might be using now, just to get kind of a sense for what you use data for, and whether or not you're looking at your internal clinical system to look at your workload tool there, or maybe you're aggregating your QOF registers across PCNs, I don't know. Do you have any dashboards that you're using at the moment, or that are supplied, or data sets that are supplied to you through your ICB? That would be really helpful to know. So if you can pop something into the chat and just let me know. You may be aware of this stuff from the UCL partners, and I think the guys at HN are going to go through some of this in more detail, but there's some free tools for you to use there and supporting resources to help you stratify your cardiovascular populations. I'm also going to pop this link into the chat as well in a little while. This is a case study from the Kumar medical practice. Some of you may have seen on LinkedIn recently, Dr. Neil Paul posted a question: is it time to change how we do QOF and similar leses, and maybe stop spending effort on patient groups who've got little to gain from that? And I know we're all saying we're time poor, we've got to prioritise and group patients. This is a really nice way to group patients by needs. Very similar to that UCL stratification. This is from the John Hopkins system, and I know there are a number of ICBs that have provided this across their areas. But speaking to Dr. Kumar last week, she tells me that she's now finding significant benefits in the delivery of that QOF work. She's doing it much earlier in the year because she's able to work out that patient need group, and that's giving her a little bit more capacity in order to deal with winter pressures at the moment. If you were on our earlier sessions, Steve Leitner mentioned the Foundry model of identifying patients who might benefit from continuity, either with a red, amber, green status. You can catch up on that session again. I'll pop the link into the chat in a moment. And one other case study, I'm not sure if Dr. Toozy's on the call, but Dr. Raza Toozy, this is worth a read as well. Also in London and maybe on the call. in this, Raza talks about a move away from a QOF just as a list of registers and start to look at the more common features of care delivery, starting to think about how to prioritise those patients. So those common features across the groups, then working out who needs to see those patients, and then moving into the best mode of contact. And I suppose I'm drawing these out for you because all of this planning is required and it will underpin the digital solutions that you've got, but you've got to do that planning. And the best place to start is with that high level data. So you can spot some of those patterns and similarities and then start to think about planning your workforce differently too. So I'm now going to hand you over to Gus and to Henry to talk about the work that they've been doing with the Health Navigator in London, using AI and analytics. We've seen a little bit of nervousness still across ICBs around using AI, but many of the patients that these systems can predict will have long-term conditions, and the plan will be to intervene sooner. Do you want to take over the screen, Guy? Do you just want me to carry on sharing the slides?
You carry on. I think we'll nudge you along.
Lovely. Okay.
So firstly, an apology. I should never start with an apology. Simon unfortunately has been away with other urgent personal. So I've roped in our COO. My name's Guy Gross. I'm a doctor. Have 20 odd years now of working in the sort of structured supported self-management patient empowerment space, alongside many other things in innovation. And I'll let Henry introduce himself.
Yeah, so as Guy said, I'm the Chief Operating Officer at AHN. My background is actually in management consulting, always in health and social care, so did quite a bit of work in operational transformation in acute trusts and ambulance services, and having seen quite how challenging the situation was in terms of demand and how difficult that really is, moved into health tech. So good to meet you all. And as Guy says, we're stepping in at short notice. I think we don't actually know what slides are coming, do we?
We don't. We'll be able to.
We'll be okay. Okay, here we go. Shall I come in on this one? So just a bit of an overview on HN. We are a precision population health management company. We basically use routinely collected healthcare data. At a minimum, it's hospital level data. That includes the emergency department, includes the inpatients, outpatients, around activity and diagnostic coding, but all sort of data assets that are generated in the regular course of delivery of care. And we use that data to develop and deploy algorithms that are able to predict adverse outcomes for specific patient groups well ahead of that crisis point. We have in the past focused on unplanned care, and specifically unplanned care in terms of unplanned bed days within hospital. And we have a randomized controlled trial that we've ran since 2015 and a very strong evidence base that using those routinely collected data assets, we are able to identify patients well ahead of time in order to enable an intervention when actually reduces risk. We have a specific clinical intervention that helps mitigate that risk, and that's our clinical coaching service, and that's something that we run ourselves and have run in the past. And I'll get into some more detail about what we're doing in North London, because that incorporates both risk prediction and intervention, which we have proven actually reduces the activity levels for patients. And you can see some of those numbers at the bottom of the screen there. 34% reduction in attendances, 24% reduction in admissions across NEL and elective activity, plus a whole bunch of data around improvements in activation levels and patient-reported outcome measures, plus, which we weren't necessarily expecting to see, plus a reduction in mortality in our RCT. We saw a global reduction of 19%, but actually, if you double-click into a specific patient cohort, male patients over 75, because of the way they interact with healthcare or don't, and we saw a massive reduction, 48%, in their mortality through our specific intervention. So it's a bit of an overview of HM. We're deployed in lots of places in England, as well as in Scotland, Wales, and in Ireland.
We can move on.
Yeah.
You should be able to see slide 10 now. Can you see slide 10? Kind of lost everybody. Kirsten, I can see you've just joined, so I'm not quite sure what's happening. Connor, are you still there?
Yeah. Guy, I think I've just allowed
Can you
your
hear us
mic and
now?
stuff. You come
There you
through as
go.
a speaker. Yeah, there you go.
Yeah, there we go.
Okay.
Thank you.
Sorry about that. Yeah, we can see the London map. We'll carry on. Sorry, I hope we got that far.
Is that okay? Yeah, so we basically off the basis of our randomized control trial, we're able to agree with NHS England at the sort of main board level to deliver a real world evidence study in London, essentially to take our prediction and our intervention further and demonstrate that actually when you deploy this in the real world, you do see similar benefits. So that's what we're delivering for at the moment. And we've actually just had our first few patients screened and onboarded into our service. We are working with NEL ICB over a 3-year period, and over that period, we'll have 11,226 patients, very specifically, both intervened and supported by the algorithm. Intervened and supported by our clinical coaches. The algorithm itself will be deployed and will assess for risk the entire population of NEL, which is 2 and a bit million people. And we're expecting to see, based on extrapolating our RCT evidence, those reductions in mortality, nearly 32,000 reduction in A&E attendances, big reductions in admissions and bed days. At the same time, we are delivering a comparator. Well, we're identifying patients in North Central London as a comparator group, and that's being independently evaluated by this, which is the University of Cambridge, is an evaluator group, and LCP, which is their commercial partner. And the idea is that after the 3 years, we'll have a really robust evidence base to say that actually, by doing this at scale in the real world, you can show the reductions in activity and you can create a really robust business case for why intervening for these patients early makes a big difference in terms of those activity reductions, but also in terms of mortality and patient outcomes across the board. We're expecting to see those outcomes improve in terms of the emergency pathway, but actually, based on the intervention itself, we're expecting to see benefits appear in primary care and across health services in NEL and probably beyond as well, to be honest.
We can move on to the next slide.
Okay, so what makes HN different? So there are typically when organizations, when NHS trusts and health systems use risk stratification models or rules-based approaches, there are a couple of limitations that HN sort of works around, as it were. So HN always retrains our algorithms based on local data, which take into account, obviously, the demographic and patient needs of that specific population. Whereas if you take something like ACGs developed over the Atlantic and then sort of plonked into the UK, there can be, when you get to the clinical facing aspect of it, limitations in terms of false positive rates and operational deployment in terms of its accuracy and delivery. You can avoid all that if you deploy and adjust your weightings on a local basis. And that's even using the ACGs and that sort of thing is better than some of the rules-based approaches which different systems use. Essentially, quite static rules, typically on limited data sources that generate big lists of patients or which contain lots and lots of false positives. And operationally, clinically, that's quite difficult to manage. And you can add in some manual screening and GP referrals into that as well. But the opportunity cost of having so many clinicians working to generate those lists is quite cumbersome in a resource-constrained system. If we jump to the next page, or unless you want to come in on any of that.
I think the most important part of this is the so what. A lot of people do population health, risk of, or huge risk profiling, risk stratification programs. But then there's two stages that come after that you have to do in order to make any value out of it. One is redesign pathway elements so that you can make sure there is a way of referring people into being managed once you've identified them as being risk. And then there's the delivery of the service. So from our perspective, you do the population health piece, you then do the pathway redesign piece, and you also can choose to either have our platform with our coaches, or you train up your own with our support to make sure that you're able to then manage risk stratify people across the board. And our specialist area and expertise is becoming more and more about how we enhance the adoption of coaching, going from what currently started, I guess, at around 20% of people who we approached identified from the list saying yes to 40%, and growing that to 60, 80, and trying to increase the uptake to make sure that in that cohort we've identified, in our case it's about 8 out of 10 beds that will be used for 4+ days over the coming 10 months. We can kind of predict through the analytics, but it's how do you then engage those people who are going to use 8 out of 10 of those episodes in hospital and get them to modify behavior. That in itself isn't something that any single service or single ICB or single commissioner generally has their hands on doing brilliantly from day one, and we do this day in, day out. So the goal is to work with our partners to help build the capability and support them in owning and delivering what they want to support those patients in those avoidable circumstances, and in fact just generally improving the health and life quality. The other big thing, and I don't know if it's covered elsewhere, is about the sort of turnover of high intensity users. I don't know if that's
we might come on to that in a
so
second.
we'll wait for that. If it doesn't come up, we'll think about that later.
Exactly. There we go. Yeah.
As if on cue.
Yeah. So the reason what we do works, from a risk prediction perspective, and then tying it, as Guy mentioned, to the actual intervention itself, to actually do something about it when you identify these patients are. The reason why it works is it's quite well known that there is a really strong concentration of high activity use in a small percentage of the population, whether that's 1% of the population at large or 5% of the hospital population use 80% of unplanned bed days. What is probably less well known is how quickly that patient group changes. So this chart here kind of demonstrates that for a specific population that we did some foundational analysis, we call it, on their patient demographics and patient activity and concentration and the like. And what we see, and what we've seen in multiple locations, is actually your high users in 1 year, and in this example, it's the top 5% consumers of unplanned bed days, is our definition of high users. And we know that changes from place to place, but that's our definition. That group, the following year, if you look at that same cohort of patients, actually 60% of those patients consume no activity from a hospital's perspective whatsoever. And a quarter of them return to mean levels of activity, should we call it. A quarter of them, enter the rest of the 95% of hospital users. And actually only 14%, and we see this range from maybe 14 to 20%, remain high users the following year. And of course, you can see on the right-hand side of the chart here, a few of those patients will have passed away over that period because they are acutely unwell. But a vast proportion of them just get better and just reduce their care activity. So if you can predict who they are ahead of time, that has real value, because your high users in 6 months' time are not your high users now. And I don't think that is particularly well understood or known in my experience. And we talk about sort of high users or high flyers in A&E, and you ask people, do you know who your high flyers, or would this sort of thing help? And people think that they can name, the top 10 high flyers that are in their A&E, and they might know some of them, but
they're 80% wrong.
They're 80% wrong because they're new people each year, and that's why what we do has value, and why NEL has worked with us in London to kind of test that at a larger scale.
I think it's also part of the main reason why a lot of population health interventions have failed is that when we do our assessment, we're looking at the whole population based on a set of dynamics that really a hospital alone or a population health system within an ICB or wider wouldn't consider. So what you end up doing is predicting based on previous behavior, which only finds when we look at our population and identify that 8 out of 10 patients, only 7% of that 100% that we've identified have ever had contact in the system in that previous period to be engaged. Have we been kicked? No, we're there. Yeah. It means that there is what is expected from known information isn't good enough. There is a whole piece, and if we can begin to attach primary care data alongside secondary care data, it actually moves us 6 months ahead in terms of being able to predict what's going to become the group of highest intensity users. And the challenge is getting that data to come together.
Yeah, we just had a question from Lisa in the chat. What does their GP activity look like as well? So we are in the process of getting GP data, primary care data for our NEL work, that we have had grant-funded research in the past into primary care activity and informed part of our RCT as well. And we have seen that you see a significant uptick, which is kind of what you'd expect in primary care activity before you see an uptick in secondary care activity. So I think it's 1.5 GP visits going up to 4.5 GP visits in the 6 months before you actually see anything appearing in the secondary care data. So from our perspective, the primary care access to primary care data is really powerful because it allows you to improve the predictive capability of the model. So you're reducing the false positives, and that percentage we talked about earlier, I think it was on a previous page of 0.86 predictive capability compared to the Harvard ACGs or whatever, which is 7.7 or 0.75. We anticipate that we can push that up to 0.9 or even further. But possibly more importantly, it allows you to bring your identification earlier in the patient pathway. And so you can deploy an intervention. In our case, clinical coaching, we've got a page on screen at the moment, which I'll go through in a moment, earlier and have a greater impact on those patients because you're able to do that before they've even touched the emergency care system. So yeah, I'll go over this page now. So we have a clinical services arm, our clinical coaching team, and it's nurse-led, remotely delivered, digitally inclusive in the sense that we typically talk to patients over the phone, but have different means of communicating them to increase the inclusivity of it. And essentially what our clinical coaches do is, across a 4 to 6 month period, deliver a sort of an initial assessment to understand the patients that are identified by our algorithm, their specific care needs, their experience of the health system, and basically understand their different typically multiple comorbidities and how they want to manage those comorbidities better. And actually what we find is the conversations and the activity that the clinical coaches undertake is generally around motivational and health education and sort of behavioral change rather than around specific conditions. So you can see that on the left-hand side of the pie chart there, the sort of pinkish color around teaching, support to self-care, motivating dialogue. It's all around building patients' capability to self-manage. And there are other elements around there around referrals and supporting patients to self-refer and the rest of it. But mostly it's around behaviors.
Yeah, I'd add to that the current state of health coaching is one that looks at things in a very linear way with PAM score or just looking at what you can predict based on the knowledge, skills, and confidence level of an individual to manage their own care. But that doesn't often take into account a huge amount of background information about the biopsychosocial environment the person's coming from, their digital literacy, the way in which they interact with the world, whether it's about their preferences or their needs and challenges. So just doing a PAM score or just looking at the sort of medical data doesn't really give you a view on how you're likely, through a single intervention type, which is often cookie cutter. And so one of the things that this whole market is going to look at, and probably led by us at some levels, is what does a platform approach look like, where you have multiple different types of intervention based on all of those different moving parts around the individual, so we can get some proper patient-centered care, shared decision-making around what is the right approach to get these people engaged more who enter our system that we've identified. That is a moving target, but it's something that, while it's complicated, still has to be dealt with, or we won't move much further than the sort of levels that we are at now, with a huge amount of uptake, a huge amount of risk identified, but we're only able to get people persuaded to take part, I would say, through various nudging activities and various engagements through letters and calls. If you opt out not to take part, then at the moment they just fall out the system. They're not managed by us. They end up back in hospital at some point, and they don't get any benefit. So we have to continue iterating and improving, and the only way you can do that is moving towards much more mass customization, I suppose, of the approaches that we take, which might mean you've got nurse-led at the front end and then non-nurse-led. You've got prescriptive and non-prescriptive advisory. You've got applications, whether those apps are structured or supported self-management tools. Bringing that all together actually means that if you can identify this, it's almost a pre-A&E intervention set. If you can identify that group of highest risk pre-hospital, when you know almost everyone who's going to go into hospital sits in this group, then taking the complexity and trying to solve that, given that you've already got that high risk group, is really something that we've set ourselves as an ambition. And I think that will multiply value in the end, because we'll not just be getting those highest activated, ready, engaged people who make up the people we engage with now, moving towards everyone within that group, and being able to support actually getting better engagement pre-hospital in primary care from the right types of conversations, rather than just, I'm not certain, what should I do, doctor? It becomes, this is what I think I need to do. Can we talk about it?
Yeah.
Super, thank you. Wow, I've got some questions, but I'm going to hand over to Connor now, and then I'm going to come back to my questions later. There's one in there from Kirsten at the moment about monitoring admission rates, so you can have a think about that whilst we're waiting for Connor to do his. My questions are around the engagement of your GP practices and how involved they feel, and then the real thorny one at the moment, which is dealing with the DCB ICB compliance around use of AI, which we're hearing lots of anxieties around that. So if you can just have a think about those things for now, and then we'll come back to those at the panel discussion, if that's okay.
Thank you.
Thank you. Thank you both. So I'm going to hand you over, folks, to Connor Price now to run through. This is a very different approach to stratification, not necessarily talking just about risk, but talking around the data that you have available to you in general practice and in PCNs. Connor, do you want to take over the screen now and share?
Yeah, I will do. I'll
Thank you.
pop back up in a second. But yeah, no, thanks for having me, Lisa. And you know, exactly like you said, this is certainly coming from a much more practice-focused perspective. I'm not going to really go into what primary care analytics is too much. I mean, the name's a bit of a giveaway for one. But I'll just put it in the chat. Visit our website. You know, see us on LinkedIn. You'll get enough information on there. So I think realistically, what I really wanted to focus on today was just trying to simplify some things. You know, I haven't got a massive amount of time, so I'm just going to sort of fly through a couple of things that are probably more meaningful, certainly to me, and hopefully to you. So yeah, definitely. So I think the key thing really here is just, you know, actually, it's just keeping it simple to an extent. But there is some things around, you know, the planning, the looking at the data side to it. So there's always room for improvement. Don't think the old way is always the best way. And that will make a lot more sense when I sort of explain what I'm going to go into a bit more. But there is a really key and important bit here, if I can move that out of the way, which is to dedicate time to analyze the data using both tools and people. And the people bit for me is really important. Primary care analytics was born out of general practice and quite literally is still owned by general practice. And we set that premise of, I started in general practice as a receptionist and worked in a GP Fed, and we've sort of born a whole data sort of environment out of it. But the majority of my team have come from general practice, and then we've brought in others from other parts of the sector and other parts of the system to bring their insights into it as well. So some of this will seem a bit simple to you, and you do have to look at it and just know what you've got access to in your own practice. But there is that key element of, actually, let's just not stick to what we've always done. And I say that because we've identified some really interesting things when it even comes to simple stuff like cough. And, having had numerous conversations over the years with practices and GPs and cough leads, who, certainly, as you can expect, just think, well, we've done cough, we've done it this way for 20 years, it is fine. The benefit with that dedicated time from people, and it is certainly people, is being able to look at it in different ways. And so, as I'd said around building this out of general practice, these are skills that we started by teaching ourselves and ultimately ended up bringing people to the team that had much better skills than I certainly had when I started it. But there's just three sort of, I guess, products that I want to show you that when you've got the products and the people together, you can see how it really starts to come together. But again, these are things that, we developed around the practice for the practice and continue to be things that can be chopped and changed, because obviously the whole premise is you've got that customizable approach when you've got a team of people to do it. So the first one, bog standards. I'm not going to lie, you guys have had spreadsheets for years and years, looking at your cough, writing down different things. If you're using EMIS, then you've got a how are you driving. But actually what this allowed us to do was to take that data out of the system, look at it in a different way, and start to break it down in different ways and get a better view then of what's happening over the years. So this is a fairly simple the one we put together. So we developed this with a practice. So we've developed it with Robin Hood Medical Centre in London. And the idea really is that, this is what I've got. I've done this on a spreadsheet. How can we now do this in a slightly more innovative way that just allows us to have that interactiveness to it, that is something that I can share with my partners and something that we can do slightly differently. And so this just very simply takes all of the domains, brings it across, shows you what the current value is, what your status is in terms of if you're treating it like a KPI, what your target is, if it's not complete, how many patients are left. But also what's quite nice and what's important with this one is also, how do I spread this out throughout the year? Now, obviously, given the time of the year it is, we're not expecting to see too much activity being done. But using this in April allows you to really plan not only your workforce, but how you deliver your appointments, how you look at your balance between on the day and routine, and then what you need for long-term condition management. So as you can quite rightly expect, by the end of this year, with the amount of patients I've got left, I need to see 1.4 patients a week. So, between 1 and 2 for an AF. So that's something I need to get jab vascular. If I go down, I can start to understand my COPD. Right, well, okay, so it's 0.3. So 1 patient a week, because I've only got 2 patients left. But you can see how you can start to plan this out. When you're looking at it from an April perspective and you're seeing that, right, I've got 1,000 patients I need to see. Well, actually, if I spread this throughout the year, then this is how many patients it would be a week. And it makes it a bit of a more manageable number. But that obviously doesn't take into account, well, I've got flu season, which is September, October, November. We're absolutely rammed and I can't see patients there. It's winter pressures in November, December and January. I've got everyone off in August. So how might I do that in a slightly different way? And what we can start to do here is say, well, actually, my summer holidays are this much. So I'm going to drop this down to 5 weeks or 6 weeks. I wanted to take into account, how much flu vaccination, what the period looks like. So I'm going to drop that down as well. What capacity I've got available to deliver things, what winter pressures looks like. And then, now it probably won't change because of the time of the year. What I would then see is these numbers start to change. And it's just that sort of proactive planning around, well, actually, okay, well, that said I had, 10 a week to deliver all of these things. But because I'm now taking into account these other things, actually, I need to do 13 a week because that will then compensate for the weeks that we haven't got anything. So what it's demonstrating is even something as simple as cough, where we've been doing it for such a long time, there is still room for improvement and how we can do it differently. The second one is just a bit of an example, and it's one that really interested me because having started in practice and being a cough lead and looking at the IT side of things, I genuinely thought, this is how we're doing it. We'll just continue to do it this way. And this is actually something that we did because of our old logo. So this is something we did a year or two ago. But it was something that resonated with me, which was having had those conversations with people across practices in the area that I'm from, and saying, well, we're going to look at quaff. Don't bother looking at quaff. We've been doing it for so many years. And what was really interesting is that we'd identified that for some bizarre reason, and this is across our whole place, 200,000 patients, that they do their diabetes foot check essentially in kind of the middle of each quarter. And you can see these spikes. That's, what we're saying then is that we've got an increased amount of pressure and activity in the middle of each of these quarters. And I took this back out to all of our practices, and not one of them could say exactly why. And what was interesting is it was something that they've been doing for so long that had fallen into a pattern and routine. And as you can probably imagine, because of people's date of birth and because of this, and it's in April, so we'd invite people because their birthdays are in April. It fell this way and no one could really explain why. And so when you then look at it this way, you then go, well, if I actually squash down those levels of activity and drag them out through a year and deliver it slightly differently, I'm not facing as much pressure in those times of the year, or even those times of the quarter, or even those times of the month. And actually we can do it in a slightly different way. So it was a real sort of tangible output of, well, you can't explain why, so let's delve into that a bit further. And now we've identified the problem. Why don't we look at a different way of, what's the solution to that problem, which evidently is breaking it down in different ways. So that was really interesting to us, and it was certainly something that we could go back out with and sort of help practices understand that using their own data then to look at ways of getting around it. And then the third one that we've looked at, and this is solely using the clinical system information. So, this is your data as a practice, being able to sort of take some of those things into account. Okay, I'm looking at my cough, so I know my long-term conditions. I'm identifying that I got, this many patients to see over the year. But I've always, I know that there's always a selection or a cohort of patients that I'm going to struggle to get in. I need to try and consider how I might do that in a different way, or certainly earlier in the year. And so we've developed this tool, which essentially, again, when you've got the people to help you interrogate it, understand it, actually get to a point then where you're identifying the patients and getting advice on what the intervention is. But even more important then is having that team of people then to be able to evidence and evaluate and show you the difference that you've made is key to this. And so this, while I would consider fairly simple, this again allows you to sort of look at that cohort, and you're in your risk strat sort of arena really, but it gives you that freedom and flexibility to delve into certain cohorts in different ways. So if I wanted to just simply look at thinking of a cough sort of perspective, I'm going to look at the patients I've got with COPD. So then I can see that I've gone from, this was a whole place-based dashboard, so I can see that I've gone from 200,000 patients down to 5,100 in my area that are registered patients who have got COPD. I can see how that's broken down across ethnic groupings, age group and gender, where the deprivation comes into that. So if I'm looking at my core 20, I'm seeing that, of my patients there, 500 or 550 of those patients are sort of within that core 20, and I might need to think about how I do that in a different way. I can look at, the BMI, and you really start to delve into not only the inequalities, but the sort of segmentation of those groups and how we might approach that, which is not the sort of typical way that we would even consider a sort of cough perspective. But then within that, so if I'm just sort of keeping on that vein, I can then start to lift different things. So this is now still keeping on the COPD. So these are still the patients that were COPD. I can see where they're sort of based and what I might do differently. And obviously, again, this is sort of GP Federation level. If I was bringing it down to PCN or practice, I'd have a sort of smaller zone that I'd be focusing on. And you really start to get into the detail of it. But what it allows us to do is just think that slightly different way, how I can then start to track some of those improvements over time. But really gives you that ability to say, right, okay, well, I know I've got a bit of an issue with these patients in terms of getting them in, or have I? And can I see which of these patients are only coming in once a year as such, and is something that I need to focus on. So I can see of my COPD cohort of patients, I've got 396 patients that only come in once a year. Now, if I know those patients are only coming in once a year, then I need to make every contact count even more important and ensure that I'm doing what I do then. And obviously, we can identify those patients within the practice system. So, you sort of moving into the sort of, your management warnings of, say, a patient comes in once a year, make sure we take advantage of them being in and spend that time with them to do the other things as well. So I guess what I'm trying to sort of quickly rattle through really is that the power of having people allows you to have this customized approach to work around you and the data, but obviously, demonstrating that having data allows you to think slightly differently about it. The only other thing I was sort of going to just touch on really was just, just something for you as a bit of a leaving thought more than anything else, is just an example of prevalence versus workforce versus PCN. So I think certainly from my perspective, when PCNs came to fruition, this idea of being able to identify these types of cohorts. And if we use diabetes, in areas where you've got a high prevalence of diabetes, actually this provided an opportunity to think about your workforce and then think, well, actually, if I can see that I've got a lot of diabetic patients or a lot of asthmatic patients that need this higher level of management, and especially even when we're looking at QOF, but obviously, we've got wider PCN contracts as well. But if we're looking at the QOF perspective, now we've moved into a realm of not needing to do this. If we said there's 5 practices in a PCN 5 times, we can look at sort of how do we understand we've got this cohort of patients. So let's work on getting a diabetic specialist nurse and share that across the PCN and see those patients once, as opposed to seeing or getting 5 specialist nurse working in 5 individual practices, each seeing 5 individual cohorts of patients. Now, where this becomes really powerful and having the data and the team to help you analyze that is understanding where that's particularly important and where you can seriously get value out of it, and just working a bit smarter, but also recognizing we've got an aging workforce, different skill sets within our workforce, different roles coming into our workforce. And so now actually we can start to use some of these tools, some of the experience we've got from people that have been in practice that are working as analysts, to then sort of look at and say, okay, well, now we've got a cohort of patients, we've got this type of workforce, how do we fit this workforce around those patients, and how do we do this at scale? And that way we can maximize funding, but more importantly, we can maximize the outcomes for our patients. And especially when we're seeing more and more roving vans, community hubs, care closer to home, and all of those things become, challenging to do at individual practice level. But obviously the balance of using people and tools, we can do that together. And there's a really good way of doing that through, primary care analytics. But the key bit is, from my perspective, a PCN, a federation, a practice can do that, but it requires dedicating that time and certainly dedicating, a bit of resource to get the people to be able to do it. So I'm going to leave it there, and I'm obviously open to questions, but obviously if you want any more information, you're more than welcome to drop me an email, website, LinkedIn, you got it. But thanks for the time.
Thank you, Connor. Thank you. And I feel like what we might have done here is a bit of matchmaking, because you've clearly got access to all the data at primary care level. Guy and Henry clearly need that information, so perhaps you guys need to go off and have a cup of coffee somewhere and work out how you can gather that.
Was our mic off? Because that's literally what we just said.
No, well, that's good if we're all on the same page, I always think. So one of the things that always strikes me when we do these kind of sessions is it's fine if you're a data geek and you enjoy this stuff and you fly around these dashboards and you look at these stats and they make sense to you. But if you're a clinician and you're focused on patient-facing services, or you're a practice manager or a PCN business manager, you've got a million other things to do, how can either of you support those people to understand the basics and know where to start? So I'm going to pass that on to HN first, because you're clearly used to using very technical solutions with your prediction. How do you tone that down in language to get people on board with your system?
I think, yes, so the technical aspects of what we do, the data science stuff and all the geeky maths stuff goes completely way over my head anyway, so I can't really engage with it particularly well. And so I ask our data scientists to explain in sort of layperson's terms a lot of things that would confuse the hell out of me basically. And so then we sort of take that a step further in terms of, okay, what does that mean? What's the so what, as guys sort of referred to earlier, in terms of when we're engaging with health systems themselves. So the 8 out of 10 figure that we referenced before in terms of the patients that you're able to identify who are likely to end up in A&E, actually, that is an amalgam of about 3 or 4 different data science metrics around specificity and sensitivity, which straight over my head, but I can get my head around 8 out of 10 patients. But then when you're converting that to what does that really mean, we have another chart which is around the waterfall effect of actually engaging with those patients, and then what does that actually mean in terms of the patients that are willing to, well, who are amenable to care, because just because you can identify them doesn't mean that there's anything you can do about it. If someone's 99 and their care needs are excessive, how much is a phone call with a clinical coach going to make a difference for their activity levels or their outcomes? You need a different sort of intervention. So you cut out those from the ones you try and intervene with. And then also a bunch of people just say no, not particularly interested in speaking to a clinical coach over the phone for a 4 to 6 month period, whatever that intervention might look like. And so you sort of whittle it down to the core patients that you can actually intervene for, that are amenable to intervention, and what does it mean for them. And that's really where we focus our communication, particularly with health systems. We've got a whole bunch of sort of case studies in terms of what those patient outcomes are from the patients themselves in terms of their experience with the clinical coaching. And to be honest, the data science never comes into any of that sort of storytelling, to be honest, because for the patient, it doesn't really matter.
No, I'm interested in the kind of handoff then between you've done your analytics, you've worked out who those patients are. You might need to screen them down a little bit further. What's your relationship with the practices or the PCNs to go, are these the right patients? Yeah. Can you do an introduction for me? Does that have more value, and does that engage with the patients and the practitioners better?
Yeah, so it's a really good question. And I think one of the things that we take really seriously is how we interact and actually minimize our disruption across the health system. So particularly from a secondary care perspective, but also from a primary care perspective, to make sure that by doing our sort of data science and our identification of patients, that we're not then chucking workload over to practices saying, help us sort of verify these patient lists. And it's sort of what I call it sort of high impact, low disruption from that perspective. And in the past, we have worked with practices to use their letterheads, for example, in terms of sending out invitation. We do all the work, but we sort of use that as the base of sending out letters, because it looks more credible coming from GPs than it does from HN. And that sort of takes a lot of work for practices. And actually, with our work in North London, that's being delivered at the ICB level. So the letterhead that we've got is North East London ICS. But that's not to say that we've not engaged with lots of practices in terms of the setup phase. So, and this comes back to one of the other questions that you asked, Lisa, or appeared in the chat around information governance and data sharing and the rest of it, that we worked closely with GP practices to make sure that there were opt-out collateral notes, leaflet things in the different GP practices where we were going live, so the patients were able to understand what the service was before it went live and say, call us up, or go onto our website and say, actually, we're not interested in having our data shared with you. And then if they let us know that, we can take it out of our data sets and we won't contact them. They won't even appear in the data that's shared with us. So that aspect, we work quite closely with them. I don't know if you add anything.
Yeah, I think there's an enormous amount here of going back to basics on how generally as a health service we engage people. We have to understand their preferred methods of engagement. We have to understand their level of knowledge, skills and confidence to manage their own conditions, and their propensity to follow up, and their ability, whether they've got a support network and other things. And that, as part of a process, is really important. It's also important not to completely, as the clinical view, taking a great clinical experience but having a rubbish user experience. And by that I mean, how often do we repeat the wheel of you know, tell me your history, because as a clinician, it's really important. I understand everything about you. So I'm going to talk to you about it, and I'm going to make you really annoyed, because I, as the service provider, think it's really important that I hear everything from your mouth and I don't get it wrong. And as a service user, it's just like, I'm engaged by you because you've told me I need to have a coach, probably, and I'm going to get 6 months of this. And now the first conversation I've had is coming back and telling you exactly what you already know, again, that I've said 5 times already for every long-term condition I've got. So it's kind of, how do you sweeten the use of this data to create a better user experience that will get better engagement? That's our most important facet, is being able to now do that. That it's part of the issue as a health economy we don't really address very well. So if you can do the intro well, if you can help really understand a person and ask questions they're not normally asked, that massively influence how they and how much they will engage with you, that for me is one of the most important things. And the people who know that best are going to be the people who have the most touch points with these people, with the patients in the community that we identify, which is going to be their GPs.
Practice, yeah.
So
Super.
finding a way of articulating clearly some of this very basic information that is non-medical directly is going to become one of the most important aspects of getting people engaged with their own healthcare. To get into structured and supported self-management, it can't just be a one-size-fits-all. And the problem is, and you take QOP as a prime example, here's the 8 bits of guidance that NICE say we should all follow. We all design our beautiful pathway. We all put a metric to achieving that tick box. We then throw these 8 things at a patient while they're with us so that we can tick a box and get paid. But in fact, the patient hasn't been listened to really at all. We have no information about why they have achieved the results that they have or anything along those lines, just because we haven't got the time to do so. So we're going to have to start thinking, if we have these high-risk groups, how do we make the time to do that? Well, actually, we're an extra resource that can engage for primary care to understand their patients better. That will not only provide a coaching service that helps, but provide massive amounts of feedback on how to engage your own patients better. So there has to be a partnership set up to make sure that within primary care, secondary care and community, as well as within these third-party providers like us, we are able to begin getting a handle on that.
Okay, super. I'm going to hand over to Connor now for the last 5 minutes, if that's okay. Connor, you clearly have lots of skills in primary care, lots of knowledge about the domain, the environment. How are you engaging with practices and PCNs to get them to see data as a central part of their service delivery and planning?
Yeah, it's a good question. I mean, some of it is what we find with PCNs and federations that use our service is essentially offering a PCN analyst. So they are there, you know, weekly, daily, they're with you on a long-term basis. So that sort of ongoing then embedment of the value of data comes in over time, because obviously you've got someone to turn around and say, oh, this is something really interesting, can you look at that? And it demonstrates the value more and more. And then the sort of flip side to that then, in terms of starting to try and to almost those not using our service, is it's working at multiple levels to have arguments at multiple levels to demonstrate why the data is so valuable. And this is what's been the success of secondary care, you know, who have invested deeply into having information teams. You know, there's a well-trodden path of how this is successful, because obviously to deliver a better service, not saying it's always a better service, but to deliver a better service, having somebody who can focus on the areas of your performance and what you need to improve and the quality, and just general activity on a day-to-day basis is really, really important. And we aren't necessarily set up to do that in a general practice. So, you know, it's not, it obviously is a thing when we look at the private sector, you know, it's there on a daily basis. So how can we do that in a practice setting that is cost effective? And I think that's where that sort of scalable approach comes to before we get to a point of being able to do it at an individual level. And that's why we set up, really, was to be able to offer that support in a way that was scalable, that was accessible, and also was cheaper than expecting everybody to go out and get their own analyst. And I think the challenge you've got, and, you know, I think what I find, and I'm trying to turn it down myself, but when I listen to Guy and Henry, is in primary care, we just haven't got that capability and expertise, which is great. Why the way you're putting it across is obviously being able to provide that at the level within primary care, but we just haven't got it, you know, and that's the challenge. And so we're starting from a point of trying to get there and recognize that we need it to be able to better ourselves. But it's quite a journey, and I think that's why, you know, trying to bring in the expertise to be able to set something up, to then be able to step away after helping them develop their own sort of team is also quite key as well. But we've got a long way to go. But I think you only have to, government, NHS England, policy, guidance, all that sort of stuff is pushing to better use of data and information and analytics. And unless we start to take that leap and do that, then we're never going to be able to keep up, and we're never going to be able to demonstrate the value of primary care as a whole. So, we need to start pretty much.
Super, thank you. So I suppose all of us have got an aim, which is to move this out of the niche zone into the everyday business as usual. Start thinking very differently. I used to be a practice manager, and somebody had said to me, find more patients, please, for you to see. I'd have said, you've got to be joking. We can't even deal with the ones that we're seeing. But there's something about saying we need to take a step back here, not just for planning workforce, but for patients' outcomes. Excuse me, and start intervening earlier. And we've started at the most basic level with NHS health checks, and a lot of practices don't even do them to get patients through the door. But I really like how can we look at the patients who might end up in hospital, and there seems for sure that need of who are we managing well in primary care, and how do we manage those in the middle, because I don't think there's a lot of room for the people who are at that very complex end. There, as your graph showed, Henry, very much they're still going to end up in hospital. But if we do something with the patients in the middle groups, so not spend so much time on the well, spend more time on the people who are in the middle groups and stop them becoming more poorly, and use the system data at primary care and wider secondary care, we might be able to do something together. So finishing at 2:00, never be finished on time. And given that we started a bit late and had all the tech problems, thanks very much everybody for staying with us today. These recordings will go on the landing page. In fact, I said I was going to just drop that into the chat, so I'll do that now. Bear with me. We've got one recording on there already. We'll be dropping last week's on shortly, and then this week's will go on, and the booking links are on there if you want to join the session. The next one we've got coming up is on the 10th of February, and that's where we'll be looking at recall. So really drilling down into how do you get in touch with people, what modes of contact, are you looking at multiple morbidities and trying to reduce those numbers of recall. So lovely to see you if you can join us on the 10th of February, and thank you very much everybody. Enjoy the rest of your afternoon.
Thank you, everyone.
Thanks now.